Today we are going to talk about bipolar disorder, mainly because it's something that it comes up quite a bit from time to time, and I think Shelley made a comment saying we probably talk about this once or twice a year as a clinician group to think about bipolar, and today we're going to focus a bit more on kind of clinical aspects of it, particularly when it comes to deciding. It's a bit of a refresher on how do we tell what's bipolar and what isn't. And so we'll dive in. So to start off with, some of the key things that we'll cover today is that, we need to address that the term bipolar gets used a lot. And I think that, it's definitely something that the community holds its own definition of, kids and families and clinicians. So it's important for us as clinicians to be able to have a really good stance. What do we think it is? How do we as professionals and experts actually say, hey, this is what bipolar is, as opposed to the community's definition and the community's understanding? And because a lot of young people come to us saying, I've got bipolar. Generally, most of what people say is bipolar is not bipolar, and that there are biological factors that we need to remind ourselves, because bipolar is real. It's a distinct problem, but it's probably not as common as it presents in our service and certainly in our sessions. So that there are, and today we'll talk about how the biological factors set the scene, but then, like all things in mental health, relationships and rhythm and environmental factors play a big role. It's a double-edged sword because, and it's important for us to be clear on our definitions and our clinical judgment, because it can be costly in either way. If we overcall it, then we're committing people to medications that have significant side effects, and we might actually miss things like relational drivers or relational developmental issues, because we've kind of launched into treating a biological condition. But if we miss it and we withhold treatment from a person who's needing it, we can actually cause some serious issues, because early episodes and every episode causes compounding damage. So it's important that that we have a good stance. So hopefully we'll get a reasonable understanding of that today. There's a lot written about the neurobiology of bipolar disorder, assessment, management. You could really spend a whole career on it. But these are some of the ones that I've used to review. Things like there's lots of guidelines, and I've also specifically looked at things like family therapy and the role of that, and the role of that in bipolar disorder, and obviously a focus on neurobiology. If there's one thing that there's going to be some really important sort of takeaway points today, and one of the things that's a key feature of bipolar disorder when you're working out whether this is bipolar disorder or not, is that it's episodic, right? That if you're gonna say that someone is having a manic episode, it's a discrete episode, right? It's discrete and it's sustained. So if you're going to call it mania, it needs to be at least a week or more, 5 days or more. Hypomania, 4 days. And there's a clear change from how that person usually is. There's a clear change from baseline. There's as we might know, there's features like an elevated or expansive or irritable mood. There's this really distinct reduced need for sleep, which we'll talk about a bit more. Then you've got these features like grandiosity and pressured speech, which is an expression of their increased thought, and their thoughts might be racing, and their activities there's overactivity that's goal driven and often related to risk. So, but this is the key, right? And this point is that it's episodic. It's not there. It comes. It stays for long enough, and then it goes away. And sometimes it takes treatment to go away. But that's got to be the first defining feature, right? And when we think about how often, how frequently it occurs, the literature is pretty consistent in that roughly 1% across a lifespan. people talk about a bipolar spectrum, where you've got sort of lesser severe symptoms, and that might say there's 2 to 3%. Onset is typically in the late teens and early 20s, so our group and our service sits perfectly at the front line of detecting this, which is why it's important for us to know. There was some time in the US where this conversation around pediatric bipolar was started to get said about which seemed to increase the published rates to almost 4%, but that's been reanalyzed and to say that the true childhood bipolar rates actually much rarer, and that actually what they were labeling as bipolar was chronic irritability, and then which led to a diagnosis of disruptive mood dysregulation disorder to try and cover that. So I'd say about 1%. So if we think about that, that's about as frequent as schizophrenia. So think about how frequent that is. There's certainly, and it's important because there's certainly a lot more people that come to us saying I've got bipolar than people coming to us saying I've got schizophrenia. But the prevalence is roughly the same. So so put that into perspective and keep that in mind. There's a definite biological inheritance feature. It's it's been well understood that it's probably one of the most heritable conditions in psychiatry, with lots of genes involved. There's good twin heritability studies that that really speak to the heritability of it. Excuse me. It doesn't mean it's one gene. It's polygenic. And then many epigenetic factors, right, that contribute to it. So we don't think there's one gene. There's probably multiple genes that contribute to the vulnerability, but then something else has to kind of push that towards the clinical phenotype or the expression. And there's and one of the things that's a feature of bipolar is that a lot of the few of the genes seem to be related to circadian rhythm and body rhythm related functions. Yeah, which I think is really fascinating to think about. It's something as discretely biological as bipolar disorder to be thought of, to have implications of rhythm, I think is really important to think about. So we'll talk about that more.
I wonder if the orexin system might be a target for next section of drugs.
That's right. But, so we'll talk about that. Look, generally, the best understanding that we still have in terms of the neurobiological underpinnings is still pretty basic, right? It's still very much top-bottom regulation failure. That there's this, in a lot of mental health disorders that we talk about, that, your limbic system's too active, and there's not enough regulation being provided by your frontal lobe, and that there is some evidence that talks about the prodrome where you can there is a distinct identification in at-risk use before they show symptoms of bipolar, that there are these sort of amygdala overactivation symptoms. And seemingly you can sort of see these vulnerabilities earlier on, but it's very hard to tease that out when it comes to children with trauma histories, children with developmental trauma, children with attachment injuries. And as we talked about before, there seems to be this, the sleep and the circadian rhythm really sits near the core of this, and that it's not. Sometimes we might talk about sleep difficulty as a kind of a feature of something like depression, for example, right? And so we've talked recently about default mode network, and that can be that's implicated in this rumination of depression, which means it can interrupt your sleep and your brain can't settle down. But in bipolar, this circadian rhythm disruption seems to actually be one of the core features of it and central to disorder rather than an effect. There's, and we think it's related to, melatonin timing and that you've got this kind of overactive stress axis and cortisol release that doesn't seem to be able to settle down across your mood states. And then losing sleep or sleep loss is one of the most reliable triggers of relapse. So, everyone who's got bipolar or diagnosed bipolar disorder, you say as soon as you stop sleeping, that is a clue that you need to do something different. You need to do something about this, because that is the first sign of a relapse. And the other, it's important to kind of think about this feature of sleep, because you might find a history of someone saying, "Oh, I can't sleep, my brain won't stop." Right? That's a bit different to the sleep feature of bipolar disorder, because in bipolar disorder there is a clear lack of need for sleep. Right? Your brain is active and driven, and you want to do things, and you don't sleep, and you feel okay. You're not tired. You don't. Like, whereas the typical history of someone who's got PTSD or some other mood disorder is, I can't sleep and now I'm really knackered, and they often have naps in the daytime. Whereas if you've got a manic episode, you have no need.
And you ask them and say, "How are you sleeping?" Great.
Yeah.
How much sleep do you have? 20 minutes.
That's right. Right. And because of the expansive nature of their thoughts, you won't even know about it because they don't come to you to complain. Because they actually feel really great. They actually feel really productive. So that's another kind of key feature if you're trying to differentiate a manic episode of bipolar from other conditions, is this distinct lack of need for sleep. And so to think about this, when we say that the circadian rhythm is a core problem, that there's just no need. Like, your body literally has turned into this super robot that doesn't need sleep anymore. I mean, how much more productive would we be if, as human beings, we didn't need to sleep? What a terrible system we have. But unfortunately, we do need sleep, unless you're in a manic episode for some reason. That look, there's obviously thoughts around how long can that go on for. Where does the burnout happen? What's the role of that in the production of the psychotic symptoms? Because your brain doesn't have those opportunities to repair, doesn't have those opportunities to consolidate. Your throttle is stuck on, and I guess at some point you have to run out of fuel. But yeah, so episodic is the first one, and the second one is that there's a different character in the sleep problem compared to the other differentials. There's this thing called kindling in bipolar disorder, which is that kindling means that once you've had one episode, it's easier to develop the next one. And also that generally early episodes might have a precipitating stressful trigger, right? Like a relational breakdown or substance use sometimes, which is a combination of factors. Whereas subsequent episodes seem to come on a lot easier, with much less precipitating factors, and that's that kindling, and and the theories around that is that that your cells have suffered somehow, right? There's your mitochondria are strained. There's some other inflammation or oxidative stress type features that's harming your cells. They're the sort of postulated theories around that tries to explain why it is that once you've had one manic episode, or especially if you've had a couple, that it tends to get easier to have more. And then the other feature that it's important for us to remember and inform families is that every episode that you have, the risk of not coming back to full function or the previous function is higher. So that the functional deficits seem to get worse with every episode that you have, which is why we tend to be pretty aggressive when we've detected a manic episode to treat as early as possible, and you absolutely have to go hard on preventing relapses, which requires a combination of pharmacological treatments and environmental treatments, as well as psychological treatments. This is the bit that's a bit tricky, because you don't kind of have it doesn't kind of look like, oh, you've got a young person who's just suddenly pops up with a manic episode. There is always a backstory, that's quieter, less specific, which features depression, anxiety, unsettled sleep, some sort of subsyndromal instability. And all of them are features of other conditions, but not necessarily specific to bipolar disorder, but they've been there. And often, you'll hear that in the adult population, almost all people who get diagnosed with bipolar disorder have had a low or depressive episode before that. and that's often the first presentation, which is really difficult to see. You might catch it where there's a kind of a switch to a manic episode after you've started an antidepressant, or some other precipitant. But often there is this sort of, not necessarily, I'm not sure it's necessarily a prodrome, but it's a useful way to think about that there are definitely features. If I was thinking, I was having a chat with some pediatricians last night about how would you tell and what would you do, and it's really difficult. And some of the factors that you can use would be, the question was, when do you pull the trigger on a mood stabilizer, for an adolescent, in primary care, for example, and when would you start thinking about that? Family history is probably, one of the biggest driving factors, particularly when you've got, a maternal history of bipolar disorder that's confirmed, particularly if that maternal history of bipolar disorder occurred in the postnatal phase. They tend to be quite predictive of increased risk in the progeny. And then if you've got, if you've got other sort of bipolar-like symptoms in, other first-degree relatives, and real ones, that which is actually can be hard to clarify, but they would be the ones that you would start to think about this more. You'd be on a bit more of an alert that maybe this is what we're dealing with. We need to monitor this a bit closely because early intervention is really important. The other things would be that that if there are distinct episodic natures, a distinct episodic nature of the young person's symptoms, you might find that that they've got kind of their features start to border more towards those bipolar symptoms. So, for example, we've talked about the nature of the sleep disturbance, the lack of need for sleep, or if the kind of the perceptual disturbances are starting to border more towards that psychotic realm, as opposed to the typical reports that we might get in someone with complex PTSD or BPD. But remember that the idea is that it has to be an episodic change from baseline, as opposed to this pattern that we get of chronic irritability that seems to come and go on a fairly and what you find, it's pretty hard to detect when an episode started and when they were last not irritable. There's a much more chronicity of it that becomes less likely to be bipolar disorder, because true mania is clearly episodic and seemingly autonomous. So what you might also find is that these chronically irritable people, it's much easier to tell the relational and developmental reactivity to their dysregulation or these symptoms. And then what tends to happen is there's a disruption in their system, particularly the relational system, and then when that system, when you think about a child in out-of-home care, when that system is a bit more consistent, the irritability settles, right? Whereas mania tends to be less reactive to those developmental and environmental factors. Right, so, and you can start, so I'm really starting to differentiate here, and there's a really different sense to what true mania is. It's a different feel. It's almost like there's this autonomous feel about it. That it's this person's engine is just running too high revs, and it's a core problem, rather than reacting to the environment or the relationships that we've got. As I mentioned before, there is this diagnosis of disruptive mood dysregulation disorder, which was introduced in 2013 to try and capture these chronic irritability symptoms that we had in children in America who were getting diagnosed with bipolar disorder. So some people will say the diagnosis is an American solution to an American problem, and it's kind of stuck. And so what this more studies on this diagnosis seems to be that it seems to predict later depression and anxiety rather than manic episodes of bipolar disorder. So if you have a child who's got chronic irritability, they seem to take a different path. So whereas someone who's got these clear, distinct episodic manic episodes, that's a very different feel, and you need to think about bipolar disorder and treat that early. But the chronic irritability picture is definitely different. Lots of difficulty working out differential diagnoses, because ADHD features high energy, impulsivity, but again these are constant rather than episodic. There's very you wouldn't really see any euphoric symptoms. You wouldn't see grandiosity, and there isn't a reduced need for sleep. There might be insomnia and sleep disturbance, but there is no reduced need for sleep. Neurodivergence is a tricky one. So autistic dysregulation, meltdown, shutting down. Where you might differentiate that is in the precipitating history. That someone who's got sensory or demand overload will lead to this mood instability, but there's clear kind of patterns of when these occur, as opposed to this seemingly autonomous feel or developmental trauma. You'll find again a clear relationship between threat-driven arousal and their mood dysregulation and BPD. BPD can be really, tends to be quite fast shifts in emotional instability, and you'll also find a pattern of that the precipitants are interpersonal challenges. So again, there's kind of more. There's more. When you take careful history and do a longitudinal assessment, there's clear patterns of what causes the episodes, and then when the interpersonal challenge settles, the emotional lability settles. There are clear relationships as opposed to what you would see in a manic episode. Obviously, adolescence on its own is features volatility. So, but they should, they should be less risky, less intense, and you can get a sense that this is fairly normal. So yeah, so look, I think that neurodivergent youth can be overrepresented in being diagnosed with bipolar. We probably need to slow it down a little bit to take the careful history around sensory and demand overload and the challenges that their social, or the difficulties in the social functioning will cause them to leading to increased arousal. So what do we do? As a clinician, all of these things that we've talked about really means that one, we need to hold an open stance that this is a serious problem that I can't ignore, but also I can't just jump in on it at my first impression, and definitely resist the temptation to go with whatever the child or the adolescent or the family say, that because there is definitely a cultural factor of that bipolar is, especially in adolescence, the number of times adolescents have expressed that that's kind of that bipolar. I can't be just depressed. It can't be just depression. There needs to be something more.
Bipolar, it's not my fault.
That's right. There needs to be something to explain my experience that has to be worse than just depression or just anxiety. So it's important to hold that, to recognize the need for understanding and an explanation. But as a clinician, a close watching over time is actually a good decision. That's not indecision. So you can't just say, I don't know what this is. It's the decision you make is, this could be bipolar, but I'm not going to jump on it right now until I've watched it over time. That's the good decision. Because and the common things that you'll see, that the common challenges will be things like complex PTSD or personality disorders. That from afar they look very similar. Pretty sure. Compare and contrast complex PTSD and bipolar is a very popular exam question for specialty psychiatry exams, because they look almost identical. They're you get mood swings, you're impulsive, you have sleep disturbance, and if you only send them to the psychiatrist for one 45-minute assessment, the risk of getting a diagnosis is high, right? Without it being without a longitudinal approach, and then and of course then you then start a path of being on mood stabilizers that actually we're treating the wrong thing. So it's a tricky thing for us because of the risk of both sides, because you also can't say, oh, it's just your trauma. That's also not a reasonable thing to say. And there are challenges in our system where, in our medical driven system and the way we go and see specialists, and the lack of the opportunities, unless you meet a threshold to be in a youth recovery wellbeing service, you actually don't get that opportunity for longitudinal monitoring, because accessing a psychiatrist is expensive and hard to get. So there's a challenge in our service delivery here for this type of condition, where you've got to make some difficult treatment decisions, because they're both serious. Some of the features that you might think about if you're wondering about complex PTSD versus bipolar 2. Obviously, if you've got the trauma has to be at the core, and obviously trauma can be at the core of both as well. But if you take a careful history about their thoughts and their symptoms, you've got this. The picture that you should be getting is one of intrusion, intrusive thoughts about trauma, re-experiencing trauma, and avoidance of opportunities to re-experience those trauma or potential re-experiencing trauma, and that you've got this sense that you've got your arousal system that's constantly stuck in your threat response, in your body, in your thoughts, in your actions, and that it's pervasive. You carry it with you everywhere you go. There's a sort of chronicity of it, rather than this episodic picture that you would get in a bipolar picture. The other thing you'll get is that if you've got trauma, is you get this kind of difficulty in your self-organization. You've got a persistent negative view of self that's chronic. You've got a relational difficulty that's chronic. You've got dysregulation of your mood that's chronic. Right? And it's a much longer picture. So you can see the difficulty here, and the importance of taking that careful history over time, taking a careful history of collateral information and family and other carers, because you're not going to get that in your first interview necessarily. And generally the mood instability is reactive. There's a precipitant, as we talked about, a reminder, a rupture, an anniversary, something in how we would typically expect PTSD symptoms to come back. Whereas, again, if it's bipolar 2 should have an autonomous sense about it. It comes, it runs its own course, and might go away on its own, or goes away with treatment. But there's not this sort of chronicity. The other thing that's important to look at is, what does the up look like? Right? What does the up look like in these different conditions? And this is probably a very, again, it takes a careful history, but there are key differences here. Right? That if you have bipolar 2, and you have a proper hypomanic episode, at least 4 days, clear change from baseline, there's an elevation or expansion of mood, or if you're adolescent, sometimes that's irritability and very clearly reduced need for sleep. I feel rested with only 20 minutes sleep. That's a very important feature. They're confident, their thoughts are fast, there's a surge of activity. Right? And because it feels good, you won't hear it. You won't hear them complain. Whereas those with complex PTSD, their high is different. Their high is a hyper-arousal. It's a stress, threat-driven activation. They're agitated. They're vigilant, and they can't sleep because they've got nightmares or racked by fear. An overactive brain that has content. So we talked about form and content in the past. That the overactivity in the brain is about fear. Is related to trauma, is related to hyperarousal, rather than I've got so much energy, I need to build a new building, and and for example, you might find that that people with trauma related conditions are more wide but miserable, as opposed to someone with bipolar who's actually buoyant, and that they can't sleep because of the threat that their brain is thinking of. as opposed to not many, no need for sleep. So these key features are probably going to help you differentiate most of them. Most of the ones you're thinking about. So, at the end of it, the affect dysregulation is our shared kind of common pathway. It's definitely hard to, kind of start from what are your symptoms now and go backwards, it's often not that clear what the precipitating factors are, and so you really do need to take really careful trauma history, really careful history of the quality of the elevated states and its pattern over time, and there's no doubt that it's difficult to differentiate, and that's why even now, despite as much as we know, it's still quite entangled, right? But if you were to err on the side of caution, a trauma-informed relational stance is a pretty safe default. You're staying vigilant for better expression of bipolar features, where you can then start a more aggressive treatment, but also you're treating trauma anyway, right? So that's I think the message is pretty clear here, and in trying to formulate it, it's really important that I don't know, you guys might hear about the stress diathesis model, right? That what you have is that you've got a vulnerability that is kind of pushed over the edge by a stressful experience, right? So that your vulnerability will be biological, kind of like this, it's kind of the seed in the soil, there's all the things, and we've talked recently about what does it take to stack the deck for a person. How do we all the little factors that contribute to a person's development? They're all things that lead to a vulnerability, and so it means that that your environment, your relationships have a lot to say about reducing that vulnerability, and that's an important leverage, because early adversity, chronic stress can not only make the onset earlier, it can also make it more severe. And that I think that that there's also this sort of interesting thing that people talk about what's the role of relationships in causing bipolar disorder. Definitely relationships are part of that vulnerability picture. But bipolar disorder, manic episodes are brain-related. It's a brain-related problem, and I guess the point is that it's rarer than we think it is. But your relationships definitely play a picture. Now, what are some of these predictable features? Those who've done some work or learning around schizophrenia, you'll hear about this phrase called expressed emotion. So, expressed emotion is probably the best researched relational variable in the more severe disorders, and that's defined as relationships that are critical, hostile, or emotionally over-involved. And if we think about some of our young people, particularly those in our youth psychosis space, they often have all of those present in either one parent or both. And whilst it's kind of thought of as a bit of a soft factor, it's so consistently replicated that expressed emotion is a high risk of onset, but also high risk of relapse, and it's across mood disorders, across psychotic disorders. And so a young person will more likely relapse in a critical conflictual home as opposed to a warm, accepting, low conflict home. And I think that if we think about that vulnerability stress model, that having calmer relationships around you is very, very protective in terms of delaying onset of it or reducing the intensity of it, and certainly reducing the chances of relapse. Which means that therapy that focuses on your relationships and family is important. That that relational work can change your outcomes. You know, it can, you know, the literature suggests it reduces relapse risk, it shortens episodes through education, communication training, coaching, problem-solving skills with your young person, and it should be something that we need to deliver like as a regular thing. That, you know, and this is the other thing in bipolar, is that we often think about the mood stabilizer first, but the family approach is an afterthought, you know, or we think about it because there's a critical family member or there's conflict, and that becomes something. Oh, gee, wouldn't it be nice if that wasn't there, you know, as opposed to it being part of, you know, equal number one to start it. If you're going to start a mood stabilizer, you should also start these. You know, especially in a service where we have capacity, you know, like ours. And the earlier that you start it, you know, especially if you can identify high risk or those young people who have more vulnerability. And what you'd be looking for is, if you've got someone who's got these mood lability symptoms, and you've also identified high expressed emotion in their family, it would serve you well to implement that, you know, and that to reduce or slow progression, reduce risk. You know, that preventative strategies, leveraging the relationship, is an evidence-based early intervention tool. You know? Again, you know, most of the time we talk about, you know, when do we start medications, you know, and we don't think enough about the evidence that relational approaches is a very, very valid and useful preventative measure. So, you know, we know that, you know, family therapy changes brain function, you know, like it's and family focused treatment, relational focused treatment leads to, you know, better outcomes. We know that there's changes in the way the brain learns. There's brain scan studies that there's outcomes related to that. And it's, you know, I know I'm kind of, you know, harping on this a little bit, but you know that the circuits in the brain that we're working on with medications can also be impacted by relational approaches. You know, they're not necessarily separate, and they are, you know, we should be thinking about the approaches that have less side effects and is probably, you know, more sustainable in the long term than pharmacological treatment. But if we go back to the circadian rhythm again, that's another thing to think about. Right, that, you know, that you've got this concept of, you know, that you know, this Zeitgeber hypothesis. It's time giver. That human beings we as creatures live on social rhythms. You know, if there's two things that we can rely on. One, we are relational creatures. We're designed to be connected. And if we don't connect, we get left behind. And it's one of the core features of any mental illness is disconnectedness from your community, disconnectedness from others. But then, you know, if we introduce today that there's this concept of social rhythms, right? And it's not, you know, it's not just about sleep and wake and day-night cycles, but that's obviously the most obvious part of it. But there's other social rhythms in terms of routines, and, you know, when we eat meals with our family, and, you know, and this is why we think, you know, when we think about young people with severe behavioural dysregulation, and the first thing we do is look at their schedule, change their routine, make it more predictable. That's the biggest bang for buck intervention, and that time and time again shows that it works. Right? Wake up at the same time. Have prescribed activity, prescribed sensory input, you know, light, you know, and you know, things like access to nature and predictable, steady social interactions. You know, all of these really, you know, easy, but for some reason we don't value them enough. You know, because we kind of don't, you know, we lay less value in them, you know, as a treatment. But, But I think that, we think about human beings as, relational creatures, and what bipolar teaches us is the importance of rhythm, social rhythm, a daily rhythm, and that's one of the things that bipolar, points to us. That, obviously there's medication is not in question. There is a clear benefit. Lithium is one of the best, one of the most efficacious medications we have. Like clozapine, right? Unfortunately, the cost is rather high, and for lithium, the cost is probably less about the side effects, more about the risk of side effects and the need for monitoring and blood tests and closer monitoring. And again, this is a service delivery problem, that we've got a really, really good treatment that we don't use often enough because we don't have the mechanisms to monitor it properly. And so we don't want to be the one who causes, the kidney problem. But, so it's not in question that medication is helpful, but we need to use two hands, right? We need to hold the medical treatment, but also we need to think about the other important factors of a human being, which is their relationships, their connectedness, and their need for rhythm. Human beings need both. And if you're only approaching the problem with one side, you're not treating it adequately enough. And some of the ideas that we bring about here is that protecting sleep and circadian rhythm. That's advice for every human being. And if you've and again, this is we only ever talk about sleep hygiene when it's already a problem, and even then we talk very kind of, we probably don't really address that well enough, because it's actually really hard to take your kids off the screens. And then, this next goal of lowering household conflict and expressed emotion, how do you do that around conversations around screen time or device use? But it highlights the real importance of co-regulation, self-care, and the fact that we need to build structures in our communities and in our service delivery to actually think about reducing the stress in the household and reducing the stress in parents. It's not something that we factor in, because we're too crisis driven. We only think about how to treat it at this end, when there's probably a lot that we can do to reduce the burden on the health system, to reduce the prevalence of the conditions, if we only, if we were able to focus on these preventative strategies. The other argument that I'll hold is that we often there's a lot of services, and rightfully so, to think about mums and mums and bubs and those relationships. What we're not really doing enough about is dads. And think about the impact of if we looked after men's mental health, that led to reduction in alcohol use and domestic violence. I've got a sneaking suspicion that would have a big impact on the prevalence of mental illness in our children. Then stuff that we know, right? Identify high-risk youth, those that are more vulnerable, and watch them. Don't jump on a diagnosis, watch them, right? Educate them. Understand what it might look like if they're going to come into crisis and what we might do. And this allows you to treat these episodes early and seriously. And it requires a shared approach, right? The clinicians and services need to work together with families. Right, so that, and the principles that we've talked about over and over and over again, right, that we bring the same stance here, that, we need to think about the nervous system and settling down the nervous system before we can talk, before we can teach, before they can learn, and you can't correct without understanding where they're coming from, right, that both go hand in hand, that, that you need to have structure and boundaries. That if you've got someone who's irritable, you still need to have limits. Right? You still need to have limits. You can't be afraid of the emotional dysregulation, which is often what happens in the family system. You're so scared of it that you don't hold your boundaries. But the answer is to hold your boundaries along with warmth and nurturing, and and the skills in playfulness, acceptance, curiosity, and empathy are is one of the ways to help you deliver a shared intention or a shared understanding or a therapeutic alliance with families. And this is we should always go back to these, that we need to think about nervous systems, we need to think about co-regulation, and we need to think about self-care. So that in the assessment and the treatment, it's a partnership. that parents will bring you, the longitudinal data, the relational data, but you need to give them the time to do that, because a cross-sectional appointment is never going to capture that well enough. And what you do is bring the framework, bring the experience of what does this, how can I tell how do I detect the autonomous nature of these episodes? And you can't do it in isolation. The parents can't solve it. You can't do it by yourself, right? And it's through this partnership that children can grow, and children can repair. So it's a common message from me.